Lizza, and also everyone online. It's a really good choice for us to have this chance to a very, very wonderful report about the stage 3 non-small cell lung cancer with EGFR mutation. It's really complex, and also always there is less evidence or standard for these patients to get the really good treatment scale, because always we just want to combine all these methods together, but actually at that what time and how many methods to use is always difficult to choose. Actually, for this special patients, for this stage 3, we always think no matter resectable or unresectable, we want curable for the it's our terminal curable, but how to be curable? The TKIs, I think, is not the good chance. It's just like to help us to maintain the disease, not progression. Is always the just like a process, but not the destination. So actually, I have this question in my mind that Professor Lizza, do you think that if we want to get curable, TKI is, I think, is not the destination, but what kind of therapy could you imagine that in the future that can get this kind of EGFR mutation patients to be curable at this stage, stage 3, or even stage 4? That's my question. Thank you.
Yeah, I think it's a very good question. And I think cure is still a long way out. I think at the moment, we should really try to find a balance between toxicity and benefit. And then I think if you want to find the patients with a good response on EGFR TKI and then either make them resectable from resectable, so add surgery or add radiotherapy to a smaller GTV, for example, I think then at least you prevent the toxicity of a large radiation field. And also, I think then you also already deselect the patients that don't do well on EGFR TKI and will progress after surgery or chemoradiotherapy. So I think for me, EGFR TKI is, I think if you start with it, then maybe you can improve the local treatment, either by having less toxicity or deselecting those that just would have progressed regardless of what you did. And I think with the new treatment regimen, so the 3rd generation TKI, the combinations with chemo or also amivantamab, but then I think the toxicity is an issue again. You can maybe improve the selection for the local therapy. But I think for the long term, it's still difficult to cure these patients, because I fully agree with you that the TKI in general will not cure the patient. I was very surprised with the ADARA results that adjuvant osimertinib results in an overall survival improvement, because you think that the mechanism of action is just that, you don't cure these patients. Maybe we need longer term follow-up to see whether it really persists in ADARA. But I think in the end also, from Professor Yi, I think somehow we need to find ways to make these tumors recognizable for the immune system, that in the end, the immune system, some form of immune therapy can cure these patients. And I think the checkpoint inhibitors, PD-1, PD-L1, CTLA-4, they will in general will not do the job. Some patients benefit, but it's really limited amount of patients. So I think we really should go back to the lab, to translational research, basic research, to see, can we make these tumors immunogenic? So I saw data with TROP2 CAR T cells, very preliminary from I think the lab of Basiana. I think it's important in the end to cure these patients that you need to eradicate the drug tolerant persistent cells, and that's very difficult. So in the lab, it was the TROP2 was associated with DTPs. TROP2 ADCs like sacituzumab, datopotamab didn't do the job by eradicating them, but it was suggested that the CAR T cells did. But again, this is very basic research, and we need to see whether we can translate it to the clinic. And the same with the vaccine trial. Some are ongoing, and we need to see the long-term results. But I think we need to go back to really the lab to see what's causing that these patients are not cured and how to improve it. But a very good question.
Thanks, Professor.
Thank you very much.
Thanks, Professor Wang. You have another question? Thanks, Professor Wang, given a very tough question, how to cure the local advance and metastatic lung cancer. It's very difficult question. We don't know the future. Maybe the immunity to recognize the tumor cells can be the future. Maybe the vaccine can be the future. Thanks to you, Professor Lizza, the good response, like the answer. Professor Shen.
Yeah, first I want to express my sincere gratitude to Professor Hendriks for the insightful presentation on the LAURA trial and the involving landscape of EGFR-mutant non-small lung cancer management. And the LAURA trial has undoubtedly shifted our approach to consolidation therapy in unresectable stage 3 EGFR-mutant non-small lung cancer. But as with any groundbreaking research, it is important clinical tracks that warrant deeper discussion. So I want to ask Professor Hendriks one question, that if the patients with bulky disease, you know that if the BRCA tumor often required higher radiation doses or larger fields, and then the patients will have the higher toxicity risks. So do you think neoadjuvant TKI could shrink tumors first, then we do the chemotherapy after the TKI? So in such cases, should we prioritize neoadjuvant TKIs to downstage the tumor before the CRT, or you think we should strictly follow the LAURA model of the CRT first and then follow the TKI consolidation? Thank you.
Yeah, thank you, Professor Xian, for also a very good question. I think the easy answer is I think you should follow the clinical trial. You have reimbursement based on the clinical trial. And I think in the Netherlands, if I would do something like induction, EGFR TKI, and then radiotherapy or chemoradiotherapy, I would run into huge problems with the department and especially the financial department, because this would not be reimbursed. But I think I agree with you that in the end, we should do clinical trials to evaluate this. I think especially with now neoadjuvant therapies, we're really only treating patients with large volume, bulky tumors with chemoradiotherapy, and this is toxic. So I think we should do efforts to downstage these patients. So even if they don't become resectable, I hope with or downstage or making the tumor less larger volume to make at least the radiotherapy less toxic. So I think if I could do whatever I want, then I would start with neoadjuvant TKI or chemo TKI, and then give radiotherapy or chemoradiotherapy and continue the TKI, because I think you're right. You should avoid the toxicity of the large field radiotherapy for these patients.
Okay, thank you. And I have another question.